We're good to go, sir.
Good evening, friends. Welcome to this Tuesday critical care classes. We try to bring some interesting topics of your interest. So this time we felt like we will bring something from ECMO, and it has been a debate that when to initiate ECMO in a patient who comes to us with a respiratory failure. So whether they are oxygen indices, like when you look at saturations, PaO2 and an ABG, or a PF ratios after initiating on NIV or a ventilator, or they are the parameters where you have to ventilate with beyond a the what we say is protective lung ventilation. For example, you need a plateau pressures more than 30, driving pressures more than 20, and you need an probably a PEEP which is causing some amount of villi with a respiratory rate more than 30 or 35. So whenever we come across these kind of ventilatory parameters to maintain minimum required PaO2 of 55 or 50, is that an indication? Or we have just only look at the oxygen indices? This has all been a common question which all we come across. So assuming we come across a case where we receive a patient with a severe ARDS, we obviously look at the PF ratios and we'll take a call whether to initially initiate on HFNC or an NIV, or we directly try to invasively ventilate them. And that is the point when we actually look at the requirement of ventilation and your oxygen indices, both PaO2 and CO2. If the gas exchange is maintained to a permissive level, with a protective lung ventilation, we maintain them on regular supine. But then if it is not maintained, the PaO2 is going below the 50 mark or a 55 mark on all possible maneuvers, and CO2 is going beyond maybe 60, dropping the pH below 7.2, we at that point of time immediately use a maneuver called proning. That's a common standard protocol, probably most of our intensive care units follow. Now, if I prone these patients, then after proning, how much time I take to see the response to the proning? What will be my PF ratio targets? What will be my CO2 targets? And how many hours of proning I will just make sure that my patient is responding to proning, and probably at this point of time I will not need any further extracorporeal therapy. Sometimes we see there is a transient improvement in both oxygenation and CO2 because of recruitability of the posterior segment of the lung after proning, but that doesn't sustain after 1 or 2 pronings. So then when to initiate? Is it after a few hours of proning or after 1 or 2 days of proning? If you find the patient is not responding to proning, then do you need this extracorporeal therapy? These are the questions always being a part of our discussion. So to bring this from 2009 time when the Caesar trial came and then followed by the recent Eolia trial, there has always been a discussion whether ECMO saves more life, ECMO is safe enough, more indications are adequately been addressed. So this has been always a area of debate. And adding to that, there will always be a learning curve for all these new gadgets and new therapies, including ECMO. See, from our school days, if we look at the mechanical ventilation, the initial mechanical ventilation was too complex and many patients were not doing good on mechanical ventilation. But over a time, we understood the mechanical ventilation theory so well that nowadays, in a regular standard care, a good amount of patients come out of this mechanical ventilation. The same thing happens with the ECMO as an extracorporeal therapy. These therapies may need a learning curve. So do we have enough trained clinician, trained centers who can actually handle these ECMO patients in a way good? So that is again one more area of concern, because we don't have a public health system where there is a proper referral to all those cases who needs ECMO to ECMO center who does a good volume of ECMO cases. We do see that the centers who actually may initiate ECMO as a first case in the local centers wherever is possible or feasible. So this is one more area, and there is a bigger concern in India that infections. So you always carry a risk of nosocomial infection in Indian context because of the infrastructural issues, because of the maybe the gram-negative bacteria being more predominant in India because of antimicrobial use or abuse. Those are again a bigger concern, and regular complication related to ECMO being always a norm. So with this all context, initiating a ECMO, the benefits of risk and benefits has always need to be weighed at the time of initiating this extracorporeal therapy. To bring this discussion, we invited Dr. Sricharan God as a ECMO physician who has been a trained and a qualified ECMO physician from both ECMO Society of India and also ELSO, and has been a faculty now to train students under him, and he has been exclusively working with ECMO patient for more than 5 years right now in Yashoda Hospitals in Secunderabad, and has also been a transplant intensivist working with a lung transplant, and has been a part of the both National Congress, and has been a part of academic for the last 2 years or so. So Dr. Sricharan will bring us some of those discussions to actually clear many of these areas, even though we do understand there is no absolute answer to all these queries right now. And with that, we also will have Dr. Pranay Oza, who is right now the president and even considered to be the one of the initial founder of this ECMO in the peripheral centers. So he will join us soon. So over to you, Dr. Charan, for your presentation.
Thank you, sir. Today we will be actually speaking about the optimal times. The optimal timing of initiation of a as sir has given a brief introduction of what the topic is going to be. So, in a patient who is having severe adult respiratory distress syndrome, is in severe ARDS, it has always been a question of debate of when is the optimal time or when is the correct time
Can we make
to
it full screen, Charan?
Sir,
Can we make it full screen?
it's full screen, sir.
Anybody from digital team?
1 second.
Close it and open it.
Now it says, is it full screen, sir?
No.
Full screen. Maximum, sir.
So before Dr. Charan comes back with his presentation, in India, we do come across with availability of extracorporeal therapy in all centers. That's not a routine process. We see this is only available in so-called tertiary centers. And then affordability. This availability and affordability is always a challenge. So we will discuss that also, and the costing because we have the
Sir, is it full screen now?
we are not able to see your screen. Yes, it is full screen.
Yes, sir. Thank you.
Go to the screen. Yes.
Okay. So, okay. So to actually speak about the preface of the topic, so we are actually wanting to discuss the optimal timing of initiating a patient on venous ECMO for a patient who is having severe ARDS. So as we all know, there are certain therapies of mechanical ventilation strategies or recruitment maneuvers, like especially proning, which can be done prior to initiation of ECMO in a patient, and then comes the actual initiation of ECMO and managing a patient on VV ECMO. However, so when do the conventional ventilation stop, and when does the ECMO management or ECMO initiation starts? This line has been quite blurry even if we take the indications of ECMO for as far as the Caesar trial, which came out in 2006. So the thing is that even though we know all studies which we have done so far, they have actually been comparing the efficacy of ECMO versus conventional mechanical ventilation strategies. Let it be Caesar trial or EOLIA trial. So they have been comparing the two major trials, or the largest trials known so far, to study the efficacy of ECMO and ARDS. So they have been trying to find out what is the ideal method of initiating ideal method of managing ARDS. Is it with conventional ventilation or is it with ECMO supports? However, what we also need to understand is that there is a point at which conventional ventilation fails and ECMO initiation has to be started, or there is a point till which we can manage with conventional ventilation alone rather than initiating ECMO way too early. So where do we actually draw the line? Instead of comparing these two, if we consider conventional ventilation as well as extracorporeal membrane oxygenation as a continuum of care, where does conventional ventilation stop? Where does ECMO start? So this is what we actually wanted to understand in the clinical context, because that is what the actual position which we will be in while taking care of the patient who is in severe ARDS. So to sum up, what am I actually trying to understand here, or what are we going to discuss, is the possible optimal timings, because there have never been a robust evidence-based guidelines on what is the optimal timing of initiation of VV ECMO. So when do we initiate ECMO? So when do we initiate ECMO? There are various other, there is the Extracorporeal Life Support Organization guidelines, which we say is when to we initiate a veno-venous ECMO for ARDS, as well as there are certain other trials, namely the Caesar trial and the EOLIA trials, which have actually made up their own guidelines in order to initiate the patient on veno-venous ECMO for ARDS. So if we actually see the indications of VV ECMO as per ELSO guidelines, it is that in ARDS with either hypoxemic respiratory failure or hypercapnic respiratory failure. So hypoxemic respiratory failure, here it is defined as a PF ratios of less than 80 millimeters of mercury after optimal medical management and absence of contraindications. And we have to remember that there is a trial of prone positioning which is added here. Similarly, if it is a hypercapnic respiratory failure, that is if the pH is less than 7.25 despite conventional mechanical ventilation. So what do they define as conventional mechanical ventilation strategies is that the respiratory rate should not be more than 35 beats per minute, and the plateau pressures or the P plat should be less than or equal to 30. That is, they should not be greater than 30 centimeters of water. So if you actually see that the what are the other relative contraindications of veno-venous ECMO is that the mechanical ventilation for more than 7 days with P plats of greater than 30 centimeters of water and FiO2 greater than 90. That is if the mechanical power that we will be discussing later. So if the mechanical power or the intensity of mechanical ventilation, if it is greater, if it is high, and it has been continued for a significant amount of times, and which is the upper limit of which is greater than or equal to 7 days, then ECMO relatively is a relative contraindication, because the chances of the patient coming out of the ECMO is significantly less, and the ECMO in these patients is associated with significantly higher mortality. So coming to the various other trials which we have known so far, the various other trials include, so we have known the indications for ECMO from the ELSO point of view, and there is also the Caesar trial which said that there is potentially reversible respiratory failure with Murray score greater than or equal to 3, or the pH is less than 7.2 because of hypercapnic respiratory failure despite optimal conventional mechanical ventilation management. And next comes the EOLIA trial. So EOLIA trials actually comes with an indication which is closer to that of the ELSO, or ELSO's indications were closer to that of the indications which we were put forth in the EOLIA trial, where the PF ratio is less than 50 for less than 50 with FiO2 greater than 80% for greater than 3 hours, or if the PF is less than 80 for greater than 6 hours despite optimal mechanical ventilation management, and or if the pH is less than 7.25, that is hypercapnic respiratory failure with pH less than 7.25 for greater than 6 hours. In these conditions, according to these studies, ECMO is indicated. Veno-venous ECMO indication is indicated. However, both of them relatively have the similar contraindications, where the peak inspiratory pressures in case of Caesar trial were considered greater than 30 centimeters of water with FiO2 greater than 80 for greater than 7 days. Or the mechanical ventilation related contraindications include quite the same in EOLIA trial, where mechanical ventilation strategies with significantly high power ventilation is there for about greater than or equal to 7 days. Both of these consider greater than or equal to 7 days as a relative contraindication for a patient who requires or who should be instituted on extracorporeal membrane oxygenation for ARDS. So, if we are actually talking about the early initiation versus late initiation of ECMO, so how are we going to define what is early and what is late? So, why is this coming into picture? Is that general consensus that if you actually look at the ELSO guidelines or the Caesar trial or the EOLIA trial, and there are certain other studies which have tried to which are more observational at this point of time, which try to measure if the initiation of ECMO, whether it is early or late, with that of the patient's mortality. So they have actually found that anything greater than 5 to 7 days, or as per the actual guidelines, greater than 7 days of mechanical ventilation is definitely considered late. So then why? So according to this paper, we can actually see that early VV ECMO implantation may be associated with lower mortality. If we actually see that this particular graph here, so the more the duration of invasive mechanical ventilation prior to the initiation of VV ECMO, we can see that the graph is almost proportional, where it is the predicted mortality is significantly high. So if at the end of 7 days or 8 days, the mortality at 5.5 days of gap between invasive mechanical ventilation and veno-venous extracorporeal membrane oxygenation tends to be around 50% at 5 days. So this is significantly higher mortality if we are considering patients for ECMO in ARDS. Now we know what is late. So anything less than 7 days be considered as an early initiation of an ECMO? So in order for us to understand what is the most optimal timing to initiate ECMO, so we need to probably look at the experts, so who have been doing ECMOs for quite some time by now, and we are actually getting the particular data from Europe. So the thing is, so this particular table actually shows the first table on the left actually shows the combined patient efficacy, combined patient population from both the Caesar trial as well as the EOLIA trial. So this is actually from the meta-analysis where they did using both the Caesar trial and EOLIA trials population. So they have found out that the interquartile time, the median time since intubation to the institution of ECMO in the ECMO group is around 35 hours, and in the control group is around 36 hours. So that is even if you actually consider the EOLIA trial, the randomization is also done in 2 blocks, namely the less than 72-hour randomization and the greater than 72-hour randomization. So any patient who underwent ECMO initiation as per the EOLIA guidelines, till they reach the point where they become a criteria for initiation for ECMO, till that point they have done conventional mechanical ventilation strategies, including prone ventilation, including inhaled nitric oxide inhalation. So even if the patient reaches the criteria for initiation of ECMO before 72 hours, they were instituted on ECMO. So from the randomization to initiation, it is quite less. If you actually look at the EOLIA trial, from the randomization to initiation, it is hardly 3.5 hours. But since intubation and mechanical ventilation in this particular population is around 35 hours or 35 to 36 hours. This is from the lifeguards group. So a lifeguard study is an international observation study of European origin. So they have actually studied around 350 ECMO patients. So in this case of 350 ECMO patients, we can actually see that the interval between initiation from ICU admission to initiation of ECMO on an average is around 2 days. And the initiation of mechanical ventilation to ECMO on an average for all patients is around 2 days. And whereas between non-survivors and survivors, it is 2 days in non-survivors with a median of with a range of around 1 to 7 days, and in survivors it is around 1 day with 0 to 4 days. So if you actually see that the p-value is 0.01, which says that this is itself is significant at 24, probably at 24 hours, because we are not actually counting this in hours here. So this itself is clinically significant or statistically significant between survivors or non-survivors in a patient, where the gap between mechanical ventilation from intubation to initiation of ECMO is around 2 days to 1 day. So we know that this is the guideline, or this is the actual truth which we see in the developed countries. So because these trials are typically from the developed world, can we extrapolate this data to an Indian scenario? Why? Because we know that from the international multi-center prospective cohort trial known as the lifeguard study, so we have known that the initiation time is not as much. If you actually see 24 to 48 hours, if we actually see in an Indian scenario, that is different. Why? Because are they actually initiating ECMO in patients how fair is the initiation? Because here I want to also comment upon the other parameters, what they actually found out in this particular study called the lifeguard study. Is it actually a fair initiation? Why am I actually questioning about the initiation, or whether or not it is a fair initiation, is precisely because of the prone positioning what they have actually done. So in these patients who are having severe ARDS, or in 350 patients who underwent ECMO for severe ARDS, in the before initiation of ECMO, only 26% underwent prone ventilation. Whether it is 23% in non-survivors versus 27% in survivors, with no statistical difference. But for we know from the 2013 ProSeva trial that the prone ventilation is going to help the patient with ARDS. It has got a definitive mortality benefit. So we have time and again seen the efficacy or the importance of prone ventilation. So we cannot underestimate the effect of prone ventilation in a patients who are having severe ARDS. Thus, 26%, if only 26% of the entire population is being prone, so what are we actually looking at here? It is because the authors in fact wonder that probably which have participated in this study, they are more comfortable in putting the patient on ECMO rather than proning the patient. And as initially even pointed out, these are public healthcare systems, so it is not going to cost to the patient whether he or not is he actually being initiated on an ECMO support, or he can be prone. Whereas prone positioning and avoiding ECMO support makes all the difference in India. So coming to the continuation of whatever we are actually talking about here. So if it is, this particular paper has actually wondered, so is it better if you use an unproven and expensive method? I can say that it is based on the, even though Iolia trial has said that there is no definitive mortality benefit, if we actually look at the combined meta-analysis of both Iolia and Caesar trials, ECMO is known to have some benefit in patients who are having ARDS, and we have seen from experience that it can make a significant amount of difference. However, so they wonder that it is unproven and expensive ECMO, is should it be done before using a proven and rather cheap method, namely the prone position in ARDS syndrome. So we can actually see that of the 672 patients who were cannulated on VV ECMO according to this study, 208 patients, that is 31% of patients, received a trial of prone ventilation before ECMO, and 69% did not. So this is a questionnaire type of study where they try to reach out to all the authors who have done ECMO and who have published ECMO and ECMO related studies, and they have, based on the reply from the authors of those particular studies, they came up with this data. So this is actually a questionnaire type of study, and I cannot consider this as robust data, but however, it is actually collaborating with whatever we have seen with the lifeguards group of study, which said that it's only 31% of patients received a trial of prone ventilation. And this is actually a rather interesting development by these authors in this particular article. So they wondered that because the ProSeva trial has come out in 2013, did the prone positioning of ARDS patients increase after 2013 than before 2013? Why? Because we know that there is mortality benefit. However, it is rather shocking that it's rather peculiar that they have found that in studies published after 2013, if they calculated, the prone positioning was used less than previously. So the p value with statistical significance, where only 19% of these patients received prone position who have done after 2013. Before 2013, almost 55% of patients received proning. So this is a significant statistical difference. So how do we actually transition? How do the transition from prone ventilation to ECMO should happen? So we all know that, as I was discussing previously, prone ventilation and an initiation of ECMO, or conventional mechanical ventilation, what is defined as conventional mechanical ventilation, and initiation of veno-venous ECMO should be considered as a continuum of care when it really comes to patient's bedside. It cannot be, in case of a randomized control trial, we can probably compare whether conventional mechanical ventilation is better or worse than an ECMO. But on a patient's bedside, it represents a continuum of care. So for us to actually take a decision whether or not the patient should be going on veno-venous ECMO, we have to define them as a prone responder or a prone non-responder. Unfortunately for us, there is no clear-cut guideline or a consensus that what can be considered as a prone responder or who can be considered as a prone non-responder. So we definitely know that there are certain complications associated with prone ventilation. or if the patient is having severe myocardial, hemodynamic instability, and there are other complications in which prone positioning is altogether contraindicated. But that is not what we are talking about here, where we want to define a patient who is fit enough for proning. Should we prone him or should we not prone him because he is responding or not responding? So the idea is, based on various other studies have taken other different criteria, where they felt that greater than 20% increase in the PF ratios after one session of proning can be considered a prone responder, or greater than 20 millimeters of mercury after proning can be an absolute increase of greater than 20 millimeters of mercury in PF ratios can be considered as a prone responder. However, these two are quite arbitrarily considered, and we don't know what is the best method to actually consider who constitutes a prone responder or who constitutes a prone non-responder. So if we can actually see, if in our current practice, especially in Indian scenario, where we see is we prone the patient, and if there is significant increase, the significant increase in the sense that greater than 20% or 20 millimeters of mercury, whatever that is, if the trend of improvement in PF ratios is significant with adequate power of mechanical ventilation, so that we are not probably introducing ventilator-induced lung injury into a patient. That is, if the P-plats are less than 30, the compliance is relatively preserved, the patient is not going into hypercapnic respiratory failure, and if there is improvement in prone ventilation or improvement of PF ratios in one cycle of prone ventilation, it is imperative that we try one more cycle of prone ventilation before we actually take up a decision whether or not to go for ECMO supports. So what are the various other things which actually determine the efficacy of whether or not we should be putting the patient on ECMO or not? So one most important thing is the mechanical ventilatory power. Mechanical ventilatory power has recently come into picture, which says that it is the determinant for ventilator-induced lung injury. So mechanical ventilatory power, by definition, is the product of respiratory rate into the work done. So the work can be defined as the change with the rate of change of tidal volumes, the change in the change in the airway pressures, and if this is integrated over the ramp, this can be we can calculate the power of mechanical ventilation. So there are various other power equations by various other authors based on the pressure control ventilation and the volume control ventilation. So ideally, no matter what what is the method of calculation, if we are actually calculating mechanical ventilatory power in these patients, this particular graph shows that this is from a study which has taken into consideration, which retrospectively looked at calculated the mechanical ventilatory power from all the data in the ARDSnet database, and from there it actually calculated the probability of mortality from the normalized mechanical power. Okay, so from this normalized mechanical power, the probability of mortality is not so correlating when the patient is having mild ARDS, but in case of moderate ARDS and severe ARDS, we can see that with the increase in normalized mechanical power, there is a proportional increase in the mortality risk or probability of mortality, which immediately says that we just cannot go on giving high power ventilation to a patient where in patients who are having moderate to severe ARDS, as this is detrimental. So for us to actually, so whether or not ECMO will help in getting the ventilator power down, the answer is yes. So this is the graph which is showing from the lifeguard registry. So this shows that after initiation of ECMO, if you see that the pre-ECMO, the mechanical ventilator power is significant, and immediately after initiation of an ECMO, we can see that the mechanical ventilator power has significantly come down. And even though post-ECMO there is some increase in mechanical power, it did not reach the pre-ECMO ranges. So even though they said that the mechanical ventilator power in this particular registry is not statistically significant to correlate with mortality after the initiation of ECMO, it simply shows, this particular graph actually shows how much we can come down on the mechanical ventilatory power by initiating a patient on ECMO, and thus giving rest to the lungs. So coming to Indian scenario has got some unique problems when we are considering a patient for a veno-venous ECMO. So we just cannot take the decision entirely based on whether or not the patient is invasive mechanical ventilation is going to be is associated with, like, if the parameters of complaints in the lungs like P-plats, everything are increasing, and if the lungs are stiff, or based on not just based on the hypoxemic or the hypercapnic criteria which we actually see in the international guidelines. So what are these unique problems which can be seen in India? These include the availability of ECMO in the center. So if the patient is, when the ECMO is not available in the center, and even if we are ventilating the patient with relatively high power, So it is redundant to actually consider ECMO in these patients unless and until we are contemplating a transfer to an ECMO center. So the feasibility of transfer to an ECMO center should also be considered in patients who are in stiff ventilation with ARDS. Second important thing is the financial constraints. So ECMO in India is associated with its own financial constraints, and these financial constraints, which are to be borne by the family, have to be taken into consideration. So sometimes, if the family is unaffordable for initiating ECMO in these patients, we might have to continue with conventional mechanical ventilation. And we also have to understand what is the awareness of ECMO among families. So when the patient is only hypoxic, and as previously discussed, ECMO is associated with its own set of complications. There might be bleeding complications, hemolysis, and infection in India is one of the major complications. So when we are actually discussing the complications of ECMO with Indian families, they might feel that probably this is doing more harm than good in patients with ARDS, where only hypoxia seems to be the concern. The patient is on ventilator, he is on prone ventilation, and other parameters look fairly okay. And now we say that this patient requires extracorporeal membrane oxygenation, but he might go into multi-organ dysfunction later, or he might go into bleeding complications, hemolysis-related complications, and sepsis and other complications. There is a chance that patients might feel that ECMO is something which is more detrimental than useful. So we have to this awareness have to be improved among in the community, that this can be considered as a very viable option in saving patients with severe ARDS. So what is the criteria? So whenever we are referring a patient to an ECMO center, what are we actually looking at here? So why is there a difference in India and beyond is that, so the ideal scenario where we actually see a patient who is being transferred to an ECMO center from a site of from the actual site of admission is clearly exemplified in the Caesar trial. The Caesar trial, in the entirety of the Caesar trial, there is only one center in one center in the UK which is considered as an ECMO center, and all the patients who are randomized to receive ECMO should be shifted to the center. And if we actually look deeper, they did not go to the center of concern and they did not initiate ECMO there and shift the patient there also. In fact, what they did was the patient was shifted to the ECMO center even after randomization, and the patient was made to keep in the original center unless he is stable enough for shifting or stable enough for transfer. Of course, this particular patient's relatively the data has been considered and has been analyzed in the randomized criteria as intention to treat analysis. However, they did not go out of the hospital to place ECMO in a remote center and get the patient to this ECMO referral center. However, so right now we have gotten the abilities and we have gotten the infrastructure which is enough for us to actually go to a remote center where the patient is receiving conventional mechanical ventilation, initiate the patient on ECMO, and then try and then get the patient back to the ECMO center. So we can either use this scoop and fly approach where we go to the center, we assess the patient, we get the patient to our center, initiate ECMO in our center, or we go to the center, initiate ECMO, and then transfer a patient on ECMO, which looks like a much more safer option given the availability of infrastructure at this point in time. So, given the various scenarios, looking like what are the conventional mechanical ventilation strategies or the recruitment maneuvers which we use, especially the prone ventilation, could they actually delay initiation of ECMO is not the criteria. So, where there are certain things where we know ECMO helps. So early ECMO definitely has better outcomes. So we just cannot keep on waiting to initiate ECMO for weeks together. It is not going to have any good outcomes. So early ECMO definitely has better outcomes. So at early ECMO, what are the criteria which we are looking at? But at the same time, if we are saying early ECMO, it does not mean that we ignore the conventional alternatives. So which have evidence-based benefit, especially like prone ventilation. So prone ventilation should be considered, and it should be aggressively pursued in patients with moderate to severe ARDS, so that probably we can get away without ECMO. It is not to postpone an inevitable ECMO. So this particular scenario is not completely valid if we are bridging a patient for a transplant, because their ECMO directly comes into picture. However, in severe ARDS, the idea of placing a patient on prone ventilation is to probably avoid ECMO altogether. It is not to delay ECMO. So we have to ideally understand, even if the patient is in prone ventilation, if the improvement in PF ratios is marginal, where his PF ratios are hardly coming between 100 to 120, and the compliance is getting poorer by the day, I don't really think it is better to hold off ECMO and then continue proning ventilation. So in these patients, proning has to be done. Sorry, ECMO initiation has to be done quite early. But we definitely know from the evidence saying that greater than 7 days of invasive mechanical ventilation with high ventilatory power have poor outcomes. So even we cannot delay the initiation of ECMO beyond 7 days at this point in time based on whatever the evidence we have. Thank you.
Very nice elaborative presentation, Charan. That was very, very good and eloquent presentation. We thank you for this presentation. Dr. Pranay Oza, sir, can you, we have Dr. Pranay Oza, who has been one of the initial ECMO, physician who has been using ECMO and reaching to the remote places, initiating ECMO and probably giving India the all experiences of ECMO. We all have our experiences back almost 12, 13 years where he initiated ECMOs in the city of Hyderabad. Also now we are seeing ECMO has been a standard of care in many of our tertiary care centers when it is needed. Pranay Oza, sir, it is a privilege to have you here. We welcome you on board, sir.
Thank you.
Yeah. Pranay, sir, now we have seen Dr. Charan giving this presentation on also guidelines on the website or on paper. It looks very clear and easy that when you have a PF ratios of less than 80 with a conventional ventilation, you prefer an ECMO. But is this scenario equates the Indian context? Many of us who actually see a PF ratios of 80, we try to prone and wait. So what is your take of those lines which has been written in ELSO guidelines, or what best follows for the all studies, either a Caesar trial or a earlier trial and all, and their outcomes we comparing with ours, and we try to actually extrapolate that. So what do you think? Is that PF ratio is a possibility in India, 80 somewhere?
Yeah. See, it's a good question. Charan has almost got everything. In Indians context, the additional point what we need to keep in mind is the logistics of arranging and initiating ECMO. That is the one thing which needs to be kept in mind. All of the trials which says that when the mortality of ARDS goes more than 50%, that time you should start considering ECMO. So you should start thinking about ECMO. And when the time comes, when the mortality is more than 80% in ARDS, that means, I mean, the PF ratio is less than 100 rather. In that case, you should think about initiating ECMO. So you should always consider initiating ECMO little earlier than, you actually require ECMO, because then that logistic time can be taken care in Indian scenario. Second thing that is important is there are many other factors that we have to always keep in mind. One of them is PF ratio, definitely that is 80. But more than that, it's not a single value which is important, it's a trend which is important. So if you are seeing that a patient is going downhill, then that is the important point that is you need to consider. Now, suppose you are giving a prone position, and after giving a proning trial, say after one trial or after two trials, there's not much of an improvement. And moment to make them supine, again the saturation goes down and your ventilation requirement goes up. In that case, there's no point in waiting for third, fourth, and fifth trial. Then in that case, you should start thinking about initiating ECMO after second or third proning trial itself. If there's no obvious improvement after proning in say 6 hours or so, then it is less likely it's going to get benefited with the proning. In that case, you should start thinking about initiating ECMO. So that is the one of the criteria as far as the PF ratio and proning is concerned. Obviously, we don't consider ECMO without proning the patients, without giving a proning trial in ARDS especially. But certain patients may not be in a position to where you can make the patient prone because of the hemodynamic instability. In that case, you might have to consider ECMO as an early option. Second thing, which is again an early indication for ECMO, is your the pH and the PCO2 levels. If the PCO2 is high to start with and pH is less than 7.2, then again that becomes an indication where you should consider ECMO as earlier. And the compliance, extremely poor compliance with your peak pressures are going about 32, 34. In that case, you should consider ECMO earlier because they are the likelihood, okay, they can go into barotrauma and something of that sort. So these are other than the PF ratio where you should think of ECMO and starting ECMO at the earlier stage.
Dr. Oza, we also see when we are actually not able to achieve the PaO2 of 60 or a saturation of 85 or 88, we tend to actually cross those plateau pressure. We tend to cross those driving pressures, which are been given as a cutoff. Okay, so is it only a oxygen indices and CO2, or also what is your ventilatory parameters? What are your plateaus? What are your driving pressures? What is your respiratory rate? What is your mechanical power? See, many of us, we think that, okay, saturation is 85, 88, CO2 is 60. Okay, they are still with the permissive hypercapnia or hypoxia limit, but your ventilatory parameters are way beyond the norms, which actually prevents a ventilator-associated lung injury. Are those also a factors that you are injuring the lung? It is time to consider about a ECMO. So oxygen indices is one side. Are you crossing the ventilatory parameters to ventilate this patient to reach those oxygen indices is another side. So do you consider them also as a indication that no, you are stretching more than required so that the lung injury can be a problem and the recovery can be an issue there?
So it is a safe ventilation, which is again an equally important aspect. Not only the outcome of the safe ventilation is equally an important aspect. It's not only the outcome, which is where you consider only the PF ratio or you just go by values. It is more important that only is the trend, number one, and number two is the safe ventilation. If the moment you are crossing safe ventilation strategy, probably you need to think about considering the ECMO at early stage.
The other point was which was raised is the time after proning. You answered it is a 6 hours. There was a question after how much time you consider prone is not effective. Somewhere between 6 hours, you take a call if it is.
Yeah. So in that, there are two things. Number one is when you prone the patient and 6 to 8 hours, the saturation doesn't improve. The saturation before proning was 78 and it remains almost 78 to 80 even after proning. In 6 to 8 hours, then probably you have to think about that the proning is not helping and then consider ECMO. Second scenario is where the patients, you prone the patient and the saturation improves to 90, 94 from 78. But then when you supine after 16 hours, the saturation goes down. And if you see the same thing is after 2 pronings trial, then 2 cycles of proning, then in that case, there's no point in continuing furthermore, and then you think about patient putting the patient on ECMO.
Sir, we do understand in India, the context is different. Even though we know these are the ideal situations where if my proning is not helping, if my ventilation is crossing the normal limits, we may need to consider early ECMO. And you give an important clue. Don't wait till that point of break comes. That's what your PF ratios, whatever you keep it as 80, keep it 60, or your plateaus of 30. But if you are seeing a trajectory that the patient is worsening, you keep preparing yourself. That's what you said. You keep preparing. You counsel the family. You make the availability of ECMO if the patient needs, so that you can initiate on them, not to wait for that till that point. That's what you are trying to point out. But sir, in many situations, we do see that availability and affordability is also an issue. So that's why we actually sometimes not able to provide these services to them. And in them, we do see that these patients were continued on prone ventilation with the same kind of mechanical ventilatory support, stretching beyond those protective lung strategy. So there we see that the harm of oxygenation and CO2 is one side, and ventilation induced injuries on the other side. So how do you balance if in those situations, these are not uncommon, where ECMO is not available and you have to manage? So what will be your targets of oxygen or CO2 there in most of the situations? Have you come across those situations?
Yeah. Again, so good question, Venkat. This is a quite common situation which we need to come. And in critical care, we have to always have to have balance between the adequacy and the safety. These are the two factors which has to be most important. When I say adequacy is, it's not the optimum number or not the best number which we are looking at. It's the bare minimum number which we have to maintain. So, if you see, during the COVID, in fact, in VV we always used to see even we accept PO2 of around 50 or PO2 of 145 also. But in COVID, most of us, all of us have seen that it's you can quite tolerate hypoxia quite well. So hypoxia is not a number. So you don't have to just look at the PO2 level of 50 and you start getting worried, or PO2 of 45, you start getting worried. What you need to see is the other supportive evidence, like case of lactate levels, how is the hemodynamics, how is the urine output, how is the sensorium. So if that is all fine, you only accept a PO2 of around 50 also. That is most important. Second factor, that is pH. The PCO2 probably will not be of much significance as compared to the pH value. So if your pH is getting altered and the pH starts going less than 7.2, then you start worrying about the PCO2 level. Otherwise, you can accept the PCO2 level. What is more important is, most of the time what I have seen is people try to target the pure saturation of more than 90 and PO2 of more than 60. And in that case, they continue FI2 of 100%. Probably, I think that needs to be stopped and that needs to be improved. In fact, you should start getting down the FI2 less than 60, if not 60, at least 80 as fast as possible, so that the you can reduce the ventilator-induced lung injuries in that case, and accept the lower PO2.
So very valid inputs, Dr. Oza. See, which we are now talking about a hemometabolic phenomenon. Somebody who has deprived of oxygen. We always see that there is an adaptable tolerance to this hypoxemia. If I don't have any metabolic challenges, like as you said, rise in lactate or cellular level indication that the patient is going into anoxic injuries or hypoxic injuries in the form, then you can probably tolerate those amount of hypoxemia and don't injure the lung. So you need to balance between the target oxygenation, which is happening at the cellular level with the hypoxia induced changes versus your lung injury. And what will be your saturation target? Is it somewhere around 85, or it is only a lactate, hemodynamics, sensorium?
Usually I give more importance to the lactate, hemodynamics and sensorium rather than the saturation per se. But 85 is a fair, good enough number, unless the patient is 60 plus, or and plus he has got some ischemic heart disease, or he has got a underlying CVA or something. In that case, probably I might target little on higher side, but otherwise, even young person, 80, 85 is also acceptable.
Okay. And there is an interesting point that you don't stretch with the CO2 too much. I have seen many of my colleagues and friends following that ARSNet trial of stretching that respiratory rate up to 35. Now we all understand, like plateau pressures, like driving pressures, respiratory rate equally harms your lung, if not the same amount of impact, but at least in some amount of impact when your respiratory rate is crossing beyond 30 or 35. So respiratory rate equally harms. So in mechanical power, we always see respiratory rate counts. So now we are using that indices as a mechanical power. The more the mechanical power, you have likely chance that your lung injuries are more. So they are trying to target it nowadays below 13 and so. So respiratory rate also equally harms. So if, as you said, the pH is somewhere between 7.25 and 7.3, you are still okay with that permissive hypercapnia. That's what you are trying to talk about.
So what we need to emphasize more on, rather than adequacy, we need to emphasize more on safety. That is most important. Rather, we forget the safety and we try to maintain the good numbers. And in that case, probably we are harming the patient more, and probably we are pushing them towards ECMO, rather than if we go by a safe practice, probably you may not push them in that way.
So the other questions are related to the cost of ECMO at this point of time in India and its affordability, sir. So we are talking to you, you being a pioneer in Atmanirbhar Bharat. We have seen some of your initiatives. So do you see that in future when the ECMO use goes up, you will find a set of ECMOs or ECMO machines in a cost-effective way, which can be available to Indian patients?
Cost of therapy when the patient is on ECMO is not only depend upon your initiation of cost or the ECMO machine cost. That is a very small part of it. Definitely, we are working on it, and probably by 2025 we should able to get the cost effective ECMO circuits and everything. But more important is the initiation time of initiation. If you initiate the ECMO earlier, then probably your number of ECMO days remains 8 to 10. If you see, go through the ELSO registration, ELSO data, most of the data shows that the ECMO run is 8 to 10 days, except for the COVID, where it takes a longer time, or except for the H1N1, which takes around 2 weeks or so. But otherwise, most of the data is the ECMO run is 8 to 10 days. And if you can cut down the ECMO run to 8 to 10 days, probably we will be able to cut down the cost to a great extent, because then in that case, you may not require higher antibiotics, higher antifungals, because it's not only the cost of ECMO which is harmful, or which makes the treatment costly. It is then you have to get added upon by the lot of antibiotics, antifungals, and then probably CRRT or something that makes the things more costly. So what is most important, I think, in getting the cost down, one factor is that you have to get it as the early initiation is going to be one factor. Second is if the availability of ECMO machine is widespread, if it available everywhere, probably then again the competitive market will come down, and then probably the cost of the ECMO therapy by the corporates and everybody will start coming down, per day charges and that.
Just because you actually brought that issue, we have seen that more and more centers are now interested in initiating ECMO. And thanks to many, the COVID and maybe ECMO Society of India and many other educational programs, which actually is giving an opportunity to most of our clinics and clinicians to actually learn ECMO and initiate ECMO. But we don't see the same kind of pattern what West do. The West has a referral centers. From all the peripheral centers, if a patient needs an ECMO, has been referred to a referral center where there is a high volume of ECMO been done, and we see a different results there. But here it always actually carries a learning curve. See, 10 years back when we initiated an ECMO, we understand we had a learning curve. Now we see that same happening to a smaller centers which are now learning ECMO or start initiating ECMO. So what is your take? I know this is a complex question that in India, we are now going through that learning curve, and more small centers also wanted to initiate ECMO. But is that going to also affect the outcome, or how do you see that?
No, definitely. There are no two doubts about the high volume center versus low volume centers. There's a huge difference in the outcome. There are no two doubts about it. But the situation in the Western countries and here is going to be a lot of difference. There, most of the time, it is the government sponsored or some insurance sponsored policies. So they can restrict the centers to get this, only 3 or 4 centers will be doing ECMOs, and then they can have a good transport program. But in India, this thing is altogether different. Most of it is a corporate nature and private nature as compared to. So restricting it to one institute and not to give to another institute is going to be an issue, because how will you judge it? That's the one thing. Second thing is even the referral will come down. If you don't have a center, in fact, even in the hospital itself, if the pediatric department does not have an ECMO machine, and if an adult has an ECMO machine, or a cardiac surgical unit has an ECMO machine, then also the indications from the ICU comes down if they don't have their own ECMO machines. So people don't think about ECMO so commonly, because then they have to arrange for the logistics, shifting and everything. So then the people don't refer the patients for ECMO. So that is another thing which you need to keep. I think the balance which can be done is those centers who have been doing a new centers, they have to do it under the guidance of some large volume centers. Probably that might be something like what we have started a tele ICU. I think what is required is something like a tele ECMO, which needs to be initiated, so that most of the time it is related to the decision making rather than the technical issues. So technical issues can be managed by the staff over there who have been ECMO trained, and the decision making can be done by the large volume centers. The experts are there from there. So probably if we can come out with a concept like tele ECMO, probably it might improve the outcome even in the low volume centers.
I think one of your fellowship programs, you are asking high volume centers to actually guide, mentor these fellows. So maybe that is one way of actually catering this so that these fellows can go down and also help the local centers if they are interested. So that's one way you are actually already doing and promoting that. So coming to the another issue related to the ECMO in India, we do see that India is a different country as far as infections are concerned. So our infections, particularly gram-negative bacteremias, gram-negative maybe VAPs are not uncommon like what we see in Western countries, and most of them being XDRs, very limited antimicrobials, and that also being a big challenge. So how do you actually tackle them and what do you do in that?
So again, if I say go back to this, most of the patients in ECMO who does not survive, I think the almost 60 to 70% they die because of secondary infection, and around 30% they die because of the bleeding issues, and hardly 10% must be dying because of the primary illness per se. So that is a very big challenge to us, and not only for ECMO, but it's a big challenge for an ICU.
Yes.
Again, the way to cut down is the initiation. If you do initiate early, probably it will make a lot of difference, because if all of us, we must be seeing that for 10 days in our ICU patient, we don't see much of a secondary infection, and then most of them do well. And after 10 days, we start getting the secondary infection. That is one factor which we need to keep in mind. Second is our all standard ICU protocols that has to be managed for infection control. Always, if you have isolated rooms, you have separate cubicles, and the nursing staffs are separate, probably that is going to make a much of a difference. That you have to treat ECMO patient, especially those who requires a long ECMO. It has to be isolated in the different rooms or wards so that yeah, the cross infection chances goes down.
Okay, Dr. Charan, you have been an expert in ambulating your ECMO patient. I have seen some of your videos where they were walking. Charan, can you be online?
Yes, sir. Yes, sir.
So, what is your take on ambulation of these patients? How do you do it, and is it the same for all patients, or there are different categories? Those who come for electively for transplant, they are a different category, and those who are in ARDS, they are in different category. Do you extubate them, or do you do a track to them?
For patients who are on who require venous ECMO for ARDS, sir, we generally don't extubate them, because the mechanical ventilation strategies with good PEEP and albeit protective lung ventilation is actually going to help them. So the thing is, if at all these patients are completely extubated, they might have some degree of air hunger. So that, as sir was telling, even on ECMO, even with some mechanical, even on ECMO, we tend to accept a relatively lower saturations, around 85 to 80%, so long as it is not harming, or so far as there is no lactatemia.
Metabolic.
Yes, sir. So these kind of parameters, if we actually consider in a spontaneously breathing patient, then it can actually trigger these reflexes where they will get tachypneic, they will breathe fast, they will try to expand the lung, and that can actually cause patient self-inflicted lung injuries. So the idea of extubating a patient and ambulating a patient, we typically do in patients who are only for as a bridge to transplant. That too with good lung reserve, and we try to maintain their oxygen and carbon dioxide targets are relatively higher. That is, we try to maintain their saturations above 90. We try to maintain their PCO2 less than 35. Unlike what we do in ARDS patients. So yeah, for patients who are on ECMO for ARDS, we give physiotherapy. We will try to mobilize them. We will try to mobilize so that it actually helps in their own well-being. But extubating a patient on an ECMO, we generally don't practice in ARDS patients. We generally practice in patients who are being bridged to transplant.
So you do a tracheostomy if needed, and you make them conscious and awake and do a physio?
Yes, sir.
Okay. Dr. Oza, sir, this is again coming back to you in these patients. What is your policy related to this, making them awake and putting them onto a spontaneous mode, or putting them onto a tracheostomy, or stopping sedation and relaxants?
Yeah. See, stopping relaxant is that is what we usually target. Say within 48 hours of initiating ECMO. Extubating, as I agree with Charan, it's not possible in all the patients. What is more important rather than looking at a number of days, most of the videos what we are seeing the patient mobilizing, moving on ECMOs and that, yeah, most of the time they are chronic lung disease or they are awaiting the transplant and they are you are able to do it. The reason is because they are used to hypoxia, they are used to hypercapnia, so you don't require the typical target of maintaining good saturation, and they don't usually trigger much in that case. So they don't require much of a support. But in acute infection, if there's an acute inflammatory phase which is going on, then in that case it's very difficult to get them off or extubated them. Once the inflammation, acute inflammation settles down, then and it goes to a proliferative phase where the lungs will, we are just waiting for the lungs to heal. In that phase of time, yes, you can able to get the person making more awake, and then you might able to even get the person extubated and can make them even move around also. But that is only in the phase when the person is going to proliferative phase where the healing phase starts. And we are waiting for the lungs to recover enough so that you can just lungs can maintain by themselves. Again, but in that scenario, if the patient develops some secondary infection, probably you patient might go down and then might have to again put them on ventilator and intubate them. So in acute phase, when there's acute infection, inflammatory phase is going on, probably you will not able to get the patient, extubated or something of that sort. But those patients which where the patient is gone into acute inflammation settle and we are going into a recovery phase and we are waiting for the lungs to recover, probably that is the stage where you can think of extubating this patient.
The other issues remains is even in spite of being in a VV-ECMO, after excluding all the possibilities of the reasons why the patient is not oxygenating well, we see some amount of lung contributing to those oxygenations. So we need sometimes a FiO2, a protective lung ventilation in them. So coming in the reverse way, suppose if my lung is somewhere still active in my oxygenation, what is this role of single cannula, Avalon cannula adding to that? I'm saying kind of a partial TPN like a partial VV ECMO, along with ventilating lung in a protective lung ventilation in an early part rather than waiting for the lungs to go to that bad. So any comments on that side?
A really very good question, Venkat. In fact, this is a big question. And if you see all the data all over the world, there's no consensus yet on ventilator settings during the ECMO. If you see the different studies, they have some studies that use APRV mode, some of them use volume control, some of them use pressure control mode. So there's no 100% consensus between what mode of ventilator needs to be planned accordingly. But what is more important is, in fact, we have started working on this theory of what should be the standard ventilator, should be the ideal ventilator settings during the ECMO. But again, that varies from patient to patient. So what will be the patient condition at that particular time is going to be difficult. Now, how much the lung is contributing, that becomes a very good factor. In fact, the moment those patients or those centers who are practicing even extubation, they also know it very well and they have published it also that the moment you extubate a patient, the lung recovery gets delayed. So if the lung was supposed to get recovered in say 5 days or 7 days, probably it might get delayed to 10 days, 12 days. The reason is the PEEP effect goes away and the lung, the added component which comes in, gets added into the atelectasis. So that is again a big question, whether to extubate this patient or no, because then the atelectasis will come into play and that will further delay the lung recovery. So those patients who are acute phase and usually in our scenario where we are seeing a tropical diseases, in that probably the ECMO run is 8 to 10 days. I always feel that you should not think of extubating this patient, continuing them on a ultra protective lungs ventilator strategy and continue them on ECMO, and probably that will be the best strategy. Those patients like COVID and H1N1, where the proliferative phases is going to be long. In that case, probably you might have to think about something of absolute rest ventilator settings or coming off the ventilator. Otherwise, in most of the time, I think you should think about ultra-protective lung ventilation plus ECMO. That is going to be a good strategy. Obviously, we need to come to one consensus, and probably it requires some prospective study for prove this theory. But then probably we have started working on that, and probably in next by 26 or so, we should be able to complete this study.
Yeah. Dr. Charan, we have seen the VV ECMO is a strategy to just give the patient oxygenation and remove carbon dioxide. It's just a bridge to a recovery or whatever things we are talking about in ARDS. But what are we doing to make the lung recover? Most of the times, if it is a bacterial, we are talking about antimicrobials. If it is a viral, most of the times we don't have an antivirals. Even in H1N1 influenza, we know after 48 hours, its role has been questioned. Then is it okay to talk about a resting lung ventilation, or we are talking about a ventilation with lung protection? Did the lung need to be kept open, or you just rest the lung? What do you think is the way what you practice?
So the resting lung ventilation settings, as Sir was studying, the resting lung ventilation settings are the ones which we actually put immediately after initiation of ECMO, that is during the active inflammatory phase. But Dr. Pranay Oza himself, he actually teaches this dictum for all of us in training that we should rest the lung, but at the same time, we should not make the lung lazy. So the thing is, if we continue on continuous rest ventilation settings altogether, the lung is just not going to recruit. At one point in time, we just have to amp up our ventilator settings, but not as much as it injures the lung, but we should make it work even from mechanical ventilation point of view. Even though our antibiotics are going to act on the lung and get the pneumonia down, the issue is that if we are continuing the rest ventilation settings, anticipating or hoping that the lung is just going to expand and the compliance is going to improve, we don't reach that point unless and until we exert the lung a little bit. So after a certain time, after the acute inflammatory phase or it actually settles, we will try to slowly recruit the lung or get the lung more into functionality. That is what we typically do. So we slightly increase the volumes and just see how are we ventilating, and we will try to keep the P-plats in a limit and see how well are we actually ventilating these patients.
Charan, we thought proning was one of the physiological way of recruiting them during ECMO, but unfortunately, the recent trial has put it down. So, what is your comment on that? That's one way. Even Dr. Oza, what do you think? I thought proning was one way of actually physiologically recruiting these posterior segments, but
yes, sir. Pro ECMO trial, the results are not at all actually encouraging. We were actually anticipating positive outcomes with Pro ECMO trial. But there are other, by the same authors actually, they have done significant observation tests. Now that it is by RCT, it is obviously, it stands above that. But there are certain other observational trials which they have done in their own hospitals by the same author actually. They have found that the compliance of the lung and has improved significantly with proning on ECMO. So I don't really think, based on one trial which was done on 82 ECMO patients, not much of a number also. So we cannot take every finding of this pro ECMO trial to be completely.
It found no difference. That's what. If the complication rates remain the same, it found no difference statistically.
See, I agree with Charan what he said. What is important is whatever trials we do, we have to understand. In fact, I think few days before I was in Kuwait in a SWAC ELSO conference, and there was I happened to meet Dr. Getinoni. And when we were discussing about the trials, he beautifully said one thing is that you have to understand one thing. What you are doing is you are using a substitute device, your supportive device. So you are using ECMO for supporting the lungs or replacing the lung functions. So it's not always true that it has to be related to the mortality difference. So that is again proning should not be related to mortality difference only. It has to be related to whether the compliance is improving or no. So there are many other factors which can be there for mortality period. So what is important is that okay, after proning the patient, are you able to get the secretions out? Are you able to improve the diaphragmatic movements, and are you able to improve the compliance? That are the more important factors rather than just looking at the mortality benefits. So probably that thing we need to always keep in mind. If you give out proning trial to the patient who was put on ECMO, and then you see after 1 or 2 proning trial, if you don't see there's any change in the compliance, lung compliance, then probably you may not continue it. But then I think it's worth giving a trial of 1 or 2 proning cycle trial to those patients who see that is one of the way you can improve the lung function, because as Charan said, I always when I talk when they come for a training course, I always try to emphasize that you should give organ the rest, but not make them lazy. So that is what is most important is proning is one of the way. If the patient is generating a tidal volume for around say 2 to 3 ml per kg, you may not think about proning the patient. Probably might think about keeping this patient on spontaneous mode of ventilator. Might be just a pressure support or something. In that case, because there has to be some diaphragmatic movement is going on, and probably that helps the lungs to recover. But otherwise, if the volume is going to be less than 2 ml per kg, probably then in that case, you think about proning the patient. Give at least 1 or 2 cycles of proning and see what happens. Definitely, it has been proved that proning on ECMO is not harmful. So, so you can always do it.
Thank you, sir. I think it has been an hour or so, and there was a lot of questions which all of has been answered. It has been a pleasure to listen to you, Dr. Oza, with our all experience and knowledge and wisdom, and you carried all that well. And I thank Dr. Charan in bringing this topic in such a short notice and very elaborately covered. And every day and every session, I'm seeing Charan getting into the groom of an expert opinion holder. He has been now contacted by our colleagues for all the ECMO queries. So thank you, Charan, for bringing this topic. And I thank all the participants who have been a part of this. I conclude the session. Thank you also. Thank you.
Thank you.
Thank you, sir.
Thank you.